My name is Teresa Shaver, and I'm the Vice Chair on the International Stillbirth Alliance Board, which I'm really excited to hear this presentation from Denise, and thank you for volunteering. Let me give you a brief introduction of Denise. Denise is Côté-Arsenault, doctor, I should say, has many years of clinical experience in childbearing family nursing as a childbirth educator, staff nurse in labor and delivery, postpartum and neonatal areas, lactation consultant, and supporting families experiencing perinatal loss. Denise's research is focused on improving care for parents who have experienced miscarriages, stillbirths, and neonatal deaths. Her research program's concentration has been on women's experience of pregnancy after or prior perinatal loss, couples' experience of continuing pregnancy with a life-limiting fetal condition, and perinatal palliative care. She has over 50 peer-reviewed publications and is the co-editor of Perinatal Palliative Care in 2020. I'm going to ask everyone to please mute yourselves, and then we'll open it up. Denise, there's often lots of questions that come in after the presentation, and I hope we can do that. I will also be following the chat and see if I can get the themes and bring them back to you. The title is Hopeful Care for Parents Continuing Pregnancy with LLFC, Research to Practice. Over to you, Denise.
Wonderful. Thank you so much. It's great to be here with everyone. So this is a very brief look at what myself and my research colleagues have been working on for the last 17 years. So this is really about an intervention that we have been testing. We developed and have been testing. And I know that there will be questions because I don't have time to share so much of what we've done. But we are very concerned about the health outcomes of parents, their own mental health, after continuing their pregnancies with life-limiting fetal conditions, which happens about 47% of the time in the United States, although we don't have exact numbers. I want to acknowledge my university, St. Louis University in St. Louis, Missouri in the US, and my research colleagues and the funding for this study. So the background really is that families face life-limiting fetal conditions in 2% of pregnancies. But parents can experience poor mental health outcomes, anxiety, depression, post-traumatic stress, as a result of losing babies, but also specifically carrying babies, knowing that they are not going to survive. In the United States, we have perinatal palliative care, which is a part of palliative care where there's extra care and support. And it's expanding in the US, but standard practices have not yet been established. So our goal with our research is to understand the parent experiences. How is it that we can support parents through their experience so that their mental health outcomes will be better and that they will actually enjoy their time with their baby? In the US, we've had a lot of court rulings which have reduced availability of abortions. And therefore, there's an increased need for parents. There are more parents who are continuing their pregnancies, sometimes not by choice. There have been no clinical trials of perinatal palliative care. And there's also a big rise, particularly after the pandemic, of telehealth, being on Zoom. And so that has really facilitated our research. So what we learned quickly is that when parents learn that that there is something seriously wrong with their baby, they move from what we call the pre-diagnosis stage of pregnancy, when the abnormality is found, into learning the diagnosis, trying to process what is it that we just learned. They want to seek information to learn and understand baby's condition. At least most of them do. Some are in denial, saying their baby is just fine, but most want, this is what we learned from most of them. But then it's being pregnant. What has happened in perinatal palliative care is a very medical approach where it's all about what's going to happen when the baby's born. I'm a maternity nurse, so it's to me, it's all about pregnancy and about what happens during the remaining 4.5 to 5 months of pregnancy. So now what? And so parents told us what it was like living with the diagnosis, then preparing for labor, delivery, initial assessment, and time with baby until death. And then the post-death period is time from death. And then for us, the end of our study. So it's important to recognize that pregnancy is a developmental process, that parents, particularly the mother's, sense of self, sense of baby changes across the pregnancy. They move from not mother to mother. And so recognizing these developmental tasks was really where we started our phenomenological study of 30 parents that we followed longitudinally. I interviewed couples, mothers, fathers together, or same-sex partners. And then I spoke with them individually so that we would get all of these different perspectives. We analyzed the data, and then the themes became a theory, which was not our intent, but that's indeed what happened. And this is what our theory looks like. So the stages of pregnancy are at the top here. So very quickly, parents told me that they were trying to navigate relationships. Everyone knew they were pregnant, but what do you say to others? What do you say when you go to work, and about your pregnancy? So that continues across the entire pregnancy period. Comprehending the implications of the condition is really, why does this mean my baby's not going to survive? What is really wrong with my baby? Then, if they do that, then they then can revise their goals of pregnancy. Okay, now what do we do? They eventually start preparing for birth and inevitable death of their baby. But the most important thing, and this is really what we focus on in our intervention, is making the most of time with baby. Parents, these 30 parents told us that they wanted to enjoy their baby while their baby was alive. And our intervention is really helping them do that. And then advocate for baby with integrity, making the best decisions that they can for their baby as parents to that baby, and then adjusting to life in the absence of baby. The overall goal, they said, is to have no regrets. At the end, they wanted to make sure that they had done everything they could possibly do for their baby. So usual care, as I mentioned, was really quite medically focused, and parents were continuing to be pregnant and require unique support, being in the world pregnant with others saying, oh, when is your baby due? How, are you having a boy or a girl? What to say, how to continue and enjoy as much as they can their pregnancy and their baby. So we knew that there was an opportunity to support parents prior to birth, and we did this through telehealth in our Hopeful study. So our purpose was to test the feasibility and acceptability of this novel, theoretically based intervention delivered to parents choosing to continue their pregnancy with life-limiting fetal conditions. And this was in addition to their usual care. We were not part of their care team. We trained providers who were nurses to guide the parents through their pregnancies and we evaluated the participant experience of completing our measures on survey, our intervention delivery, and then the use of a journal. So the theories that really are the foundation of our intervention is the theory of caring, being there, but coming across in a very caring way. And I could go into much more detail about that if anybody's interested. The developmental tasks of pregnancy that I just showed you, and then the concept of prenatal parenting, which is really that you are already parents. They are already parents during pregnancy, and how to really make the most of that. So the intervention components were as soon as after diagnosis as possible. They entered our study. They had one of our intervention nurses. They had the same one the entire time. They met with them several times during pregnancy. They built an ongoing caring relationship with that caring theory. The nurses assess parental understanding and needs. Where are they in their developmental tasks? Addressing where they are, meeting the needs where they are, not just focusing on what is yet to come. So what are their needs, and empowering them to do what they can for themselves and help them do what they can't do on their own. Promoting perinatal parenting, which is really, you are the parent. This is your time to parent your baby. Help them build some hope, if that's possible for them, and positive memories, and spend time with their babies. So some of the quotes we received from parents was, the sessions were really beneficial as they gave me a chance to talk about my pregnancy experience and also talk about my child in a good light, as most or all people don't want to talk about her or the pregnancy. It was very helpful to hear some things coming, what we should be looking towards. It is just so meaningful and appreciated. These parents really didn't have many places to talk about what it was like being pregnant, and what it was like, who their baby was, and what they had hoped for their baby. And another said, I feel this program has had a positive impact on me personally to speak freely and openly without any fear or judgment. A father said, sessions brought us together as a couple. And then there was the suggestion that perhaps, like, some of our sessions would go an hour and a half or 2 hours, whatever it was that they wanted. And one dad was like, I would prefer 30-minute sessions. So it was a little much for some of them to really focus on this for a period of time. However, we found that all of our parents stayed in the study the entire time. Recruitment took us a while, but everybody stayed in the study. They found the intervention helpful and appreciated it. One mother, we got lost with total follow-up, I think because of dissolution of her relationship with her partner. And we had a minimum of 5 sessions with each couple or mother. There were some single mothers, and if they wanted more, they got more. The telehealth sessions were flexible scheduling, so we did it on their time. They easily took our surveys. Training the nurses was a challenge, and we're working on that. We're revising our training program. So in our surveys, we had them respond to questions about their pregnancy anxiety. And in fact, their pregnancy anxiety went down across pregnancy. At the end of the study, they had low to moderate, mothers had low to moderate decision regret, and it was even lower for the fathers. So that we thought was, rather, because that was their goal that we had been told in our previous study. Grief intensity at the end of the study was low moderate. Of course, they're going to still be grieving, but we did not have a comparison group. So we are still working forward to that. So just to give you a little sense of what this might look like. So this is a case study. You might be meeting with a family at 26 weeks gestation, and they've just come to you. You're just learning about them. And you learn that the dad does not want to tell anyone about the diagnosis he's feeling. We just don't know. He is really, if you think about the tasks, he is trying to comprehend the implications of the condition. And he really is hesitant to really know, and he doesn't want to tell anyone. So he doesn't want to navigate relationships. However, his wife um, has very few people to talk about her worries because her husband is saying, let's not talk about this. So they are definitely in the um, adjusting to the fact that they have this diagnosis. And I've already shared with you their developmental tasks that they're in. The caring process that we would suggest that you might use is to, first of all, know their story, be with them, spend time with them, develop that relationship with them, and then reflect back. This is what I hear you saying. Is this what you mean? And then really, like mom was being, had few people to talk to. And then how do you feel about that? So really provide them with a time to just have time to talk and us reflect back what it is that we're hearing. Now, a month later, the mom has called a funeral home. So she has developmentally moved from trying to understand what this condition is to revising her goals and starting to prepare for her baby's birth and death. The dad wants mom to just enjoy the pregnancy. He is still in denial. They have not told their older children anything other than that they're pregnant. So mom and dad are in two different places. So, what we did during the intervention is separately meet with the mom, listening to her saying, how is it, how does it feel? You're calling the funeral home, but your husband is in a very different place, and helping her negotiate that. Um, and just what is it that she can do, which is part of the caring process, to work this through with her husband. And then they delivered their baby, and baby was confirmed to have trisomy 13, and is in the neonatal intensive care on mechanical ventilation. The father is confronted with the reality of the diagnosis. So he's developmentally, he really is not where he would have been, because he was still trying to deny that this was even a possibility. The mother, however, was enjoying time with the baby, even though the baby was in serious condition. But the baby went home for a couple of days, then had some respiratory distress and color changes. Baby was readmitted to the hospital, and the baby died within 24 hours. But that baby lived for 57 days. So they had time to adjust and continue to talk with our intervention nurse. So then they were left. Now they had to tell and tell everyone so that they could get the support that they needed. So that's just an example of how this might come up through. So the pilot study pearls were the benefits of meeting parents in their daily lives. Was the parents loved it. When parents were hesitant, we could plant some seeds and to say, you might start thinking about this or that. And then the training of the nurses was, they were used to helping parents after the babies died, and here they were with during pregnancy. And our goal is to engage the palliative care or fetal team members and teach them this approach. And if families do not receive needed support from our teams, they will search elsewhere. So we want to provide that. So it's time for questions.
Denise, that's I just want to say thank you. And this kind of research is so, so important, and we need more. And I really applaud you and your team, and for the time and for the research that you did, and everything that you are doing. So let's really open it up. You can go ahead, unmute yourselves, and ask questions. All right. There must be questions. I can't believe that there would not be.
I have a question for everyone. I'm wondering how prevalent perinatal palliative care is from in all the places that you're from.
Please unmute and just come on.
Denise, I will start because I just want to say hi. I've just used and read your work for years and have appreciated so much and really put a lot of your stuff into our program. So thank you for everything
Wonderful.
you've done, all your great work. And I would say I'm in Minnesota, and I would say that in the last 5 years, we've really, really gotten everybody on board for this. For about 10 years, I really met resistance by a lot of people, MFMs and others. But I would say in the last 5 years, I think we're doing this really, really well. And I liked your scenario because I think it's typical, where you just can't get everybody on board right away to do planning, to decide what they want to do. So I love that you had, a mom who was ready to do that, but then a dad who wasn't. And then how do you deal with that? Well, you just kind of walk through with them, right? And meet their needs where they're at. So I really appreciated that because it doesn't always just look all, I like to get everything on paper, everything set, everything planned, and it just doesn't always work that way.
It doesn't.
But thank you, Denise, for your
Well,
work.
thank you so much. I appreciate that.
Amanda, go ahead.
Hi, thank you again, Denise. This is really fascinating. And again, I'm a big fan of your work and wanted to ask, you mentioned about challenges with the nurses in moving to prenatal hospice care. And I was wondering a little bit more about how you helped nurses reframe their role. So.
Yes. So in looking for who was for our study, we needed to be able to train others. And so we wanted people who were worked in maternity care, had the knowledge that we needed, and perinatal bereavement skills, but we also wanted to teach them our way of doing this intervention. So we didn't want those who were currently in perinatal palliative care. And so the nurses that we recruited were fabulous, but they were not used to working with theories. So for them, it was like, theory? What's a theory? And how can I possibly use a theory and understand a theory? So we spent a lot of time trying to change the language because it just seemed like such a strange language to them. Then we practiced with them, taught them reflective listening, which they realized they really had that skill. They just didn't call it that. And then provided them reading material. And then we used actors. So once they understood the theory and they realized, understood what pregnancy was really like, which they knew, but not in this context. Then we had actors who are medical actors, so they played the couple, and then they interacted with them, and the couple were the parents currently pregnant, and then they could respond, and then the couple could say, "This is how this felt," or not. And they were a little hesitant to that, so I started them off, and then they're like, "Oh, I can do that." So it's really new language and practice. So going through case studies and then just making it the environment of training to just be very relaxed. And then they were fabulous. Then they loved it. So thank you for the question.
Great. Anyone else?
I'll unmute real quick. Hi, Denise. My name is Sarah Rodriguez. I met you at the PLIDA conference. I am the Research and Education Coordinator for Star Legacy Foundation. So nice to meet you. And this is just such great information. I just wanted to share that at Star Legacy, we realize that families that we serve who've chosen perinatal palliative care have shared with us that childbirth education was a place where they felt it really wasn't inclusive for them. So we are developing a childbirth education class in coordination with Columbia University, New York Presbyterian, and the Neonatal Comfort Care Program to serve those families so that they can get that information that they need as far as labor and delivery and all of that, but in a place that's safe with like-minded folks, and that they can ask those questions. And they don't have to go to a childbirth education class where 99.9% of the folks in there are happy, excited. And again, they don't have to explain their story. It's a safe place, and it's catered to what they may experience. So we're really excited about that. Still in the planning phases, but we've really noticed an uptick in requests for perinatal palliative care information, education, and things like that. So thanks for all of your work, and we're hopeful that we can get this going here in the next year and offer it to families across the United States and globally.
Thank you, Sarah. That sounds really exciting. And we, our nurses during this intervention ended up providing some of that. And in our current study, we really didn't have a very diverse sample. And so we've been working with and hearing from parents who are persons of color, their experiences. And the one thing I would just say, Sarah, is I hadn't really thought about this, is really a couple of them really said that no one ever even mentioned to them that the chance of stillbirth is increased with these fetal diagnoses, and that they were not prepared for that or for induction. So I would just suggest, if add that to the childbirth education that you're planning. It sounds great.
Denise, we have one comment from Odessa. And Odessa, please, can you unmute, and would you like to ask it?
Okay. Hi, everyone. My name is Odessa Omanyo. I am from Nairobi, Kenya, a neonatal nurse. I'm also an ISA board member. Very happy to be here, and also to just applaud you, Denise, for that amazing presentation. I think I can maybe share what I have on my side. I planned to join a palliative group. There's one in Kenya, and I thought maybe they'd have something in perinatal palliative care, which was nil, and I was really surprised. People are only focusing on hospice care, cancer and all that, and they really forget this group of people who just want to have someone work with them. Exactly. So I'm really, really impressed that about your study and how it came about. I think for us, we have a gap in even genetic counseling. Most of our clients just appear at maybe second stage of labor. Maybe they didn't even carry out an ultrasound during pregnancy, and now they're just surprised getting, babies who are, having issues or maybe syndromic, and they later on die or even die during labor. I think your presentation really spoke to me, and I see the gap that we have as a country, and maybe we can link up and see how we can support such parents.
That I would love to have a private conversation and see what it is that we can do to help. That we, it sounds like there are many needs, and happy to help.
Oh, thank you.
Thank you, Odessa. Catherine, I see you have also a comment. Would you like to unmute yourself?
Sure. Hi, Denise. It's wonderful to see you again. And thank you. This work is fabulous. When you were recruiting for the study, I was working in the NICU and often ran into the dilemma of not being able to link families in a timely manner with what you were researching and studying. So I think that what I would love to see is more education going to not only just MFMs and providers at diagnosis, but also to genetic counselors to understand that there are options for slowing it down. What I have seen personally in my private practice with mental health is that these families are given 3 days to decide whether to terminate or and I don't think they understand what palliative means for their
Right.
baby, for their family, for their mental health, for their parenting for the next 20 years. And so I think that's just a real missed opportunity to educate providers on offering options. So just the slowing down the process and allowing
Yeah.
natural time to progress.
Yeah. Thank you, Catherine. I totally agree. And options, with our current study, parents have just said that they were given no options. They were just told you need to terminate and you need to, just as you're saying, you need to terminate and you need to make this decision very rapidly. And but these parents had their babies had previously died and they were just saying, no, we don't want to terminate. We're not going to do that. This is our baby. And then several of them, they never got perinatal palliative care. They were kind of left on their own. And so, yes, we need to continue to educate everyone and it will take some time, but we're hoping that with an intervention that we know is very helpful, that we can spread the word. So thank you, and thank you for your work.
Great. Is there anyone else? Please just unmute yourself and ask any questions. We still have time.
Yeah, this is Adolf from Rwanda. Thank you, Dennis, for fabulous presentation. Really appreciate the fundings and the work you have done for that. And I have like small concern about the case study you mentioned about the baby born with trisomy 13.
Yes.
Where the father was concerned about the diagnosis and the mother probably seems to was not aware of the condition maybe you had. I don't know if I was mistaken to listen about that. I was wondering, was not having any clear diagnosis and information from providers and the doctor and MFM specialist to talk about the diagnosis, even the baby born with that trisomy and possible information about the condition and the prognosis and everything, so that both parents get like clear information about the condition of the baby.
Yes, thank you so much. The parents did have ultrasounds, and there were the classic signs of trisomy 13, but the father, this was his first baby and his wife's fifth baby. So he just did not want to, he wanted to hang on to the words of I think what was said to him was, well, we don't know exactly what kind of condition your baby will be in at birth, which is true. And he just hung on to that, and he was trying to take on the role of being strong and no, we're going to enjoy our pregnancy. And so it was more him, some parents are just, they don't want to hear the diagnosis. They don't want to hear the likely prognosis. And so, this is not such an unusual situation. So, and then once the baby was born, and then they also did not want to do an amniocentesis to get a genetic result because of the risk of potential miscarriage or stillbirth of the baby from amniocentesis. But once they did the genetic testing after the baby was born and seeing the baby, then it was quite clear that indeed the diagnosis was correct. So we're often in a situation similar to that. So yes, so we have to take parents where they are and walk their journey. I think Odessa said that is to walk with them.
Thank you, Denise. Anyone else? I don't see any hands or any mutes coming off. Well, it's okay to end a little bit earlier. Denise, is there anything you'd like to say in closing? And then I'll just wrap it up.
I think it seems that, there have been no questions about following these parents through pregnancy. We know that is trying to integrate this into perinatal palliative care in general will be challenging, which is what we're working on now is developing this training. But it may be time consuming, but in the long run, the parents will be in a much better place. And it's really who is it that would be walking with them. And so perinatal palliative care coordinators are really the ideal person. We've done a study about them as well, and those publications are out there. But it's really changing the mindset of walking with them through their pregnancy journey. And what is routine is that if parents come to a perinatal palliative care provider or several that they meet all in one day, then they are quick to say, okay, you need to write a birth plan, make your decisions, and once again, very focused on getting to the end point and to realize that you really need to hear where they are, meet them where they are, meet their needs, and help them to move forward and to make the most of their time with baby. And the one amazing thing to me, I must say, having been a maternity nurse for a long time, is that when I worked in labor and delivery and someone would come in and there was no heartbeat, fetal heartbeat, and then we would immediately take them to a labor room and start Pitocin and start an induction. All I saw was tears with these parents. But with this group, even me interviewing them, even not actively trying to intervene, but just listening, they called me with such stories. They were so excited to meet their babies. They took balloons. They had blankets with their baby's name on it. And they were like, we saw our baby and she looked at us for 15 minutes. It was fabulous. And I was blown away. I thought, what a contrast. It's really providing the time, support and time to prepare, and to really, recognize that they really can be good parents doing what they're doing. So that to me was really life-changing. So.
Denise, I can't thank you enough for what you're doing and the research that's coming forward. And I would ask if you could also maybe provide a link to the Perinatal Palliative Care, the clinical guide for
Sure.
the viewers. That would be great. And as a retired nurse midwife, I so relate with what you just summarized and ended with. And it's such important work, and for us to really make it not as research only, but research into action, and that it's common in every facility where birthing is taking place. So thank you. I also want to just make a pitch to everyone. This will be recorded. It will be on the International Stillbirth Alliance website, which I hope everyone is going to. There's lots of recordings from other presenters also on there. And there is also sharing tools and research and materials. So please join us and be a member of the ISA. I always say, as a member, it's really the heart of ISA. It's who we are. So Denise, thank you. Thank you for your time and being a part of our journey. And thank you.